I'm here with Professor Albert Ferro from the UK and Professor Peter Clemensen from Denmark at the 17th Congress of the International Society of Cardiovascular Pharmacotherapy. Professor Ferro and Professor Clemensen just co-chaired the session this morning and also made presentations. And a number of issues actually emerged during this session, and I would like to rescue some of those. If I could start, Albert, by asking you, your talk actually raised an important issue in relation to the new antiplatelets, and you correlated that with what we knew about aspirin and clopidogrel. What would be the sort of key message that one would take home from your presentation?
I think there are a few messages. We have the older agents, we have aspirin, we have clopidogrel, we know they work very well. We know that dual therapy with aspirin and clopidogrel is a very good lifesaver in the setting of acute coronary syndrome. However, we do have some newer drugs now which have some advantages. They have more predictable pharmacokinetics, they're more effective than clopidogrel. There is a reduced need for routine platelet monitoring with these drugs because there's less variation in response. But on the counter side, they do cause an increase in bleeding simply because they are more effective as antiplatelet agents. And importantly, in these austere times, they're significantly more expensive now that clopidogrel is off patent. So that raises an issue in terms of can we afford these newer drugs to use routinely in place of clopidogrel, which is now very much cheaper.
What would be the key advantages or disadvantages of incorporating the new drugs into the guidelines? Because I mean there is a clear move in international guidelines to incorporate these drugs because they have shown benefits in that.
And in particular because the newer drugs have a faster onset of action. So particularly in the setting of high-risk ACS patients and in patients where rapid onset of antithrombotic efficacy is needed, then these agents have a clear advantage. And also one of the questioners in our session raised the issue of it's not just to do with variation in clopidogrel response, but it's clinical treatment failure as well, that even if the platelets respond as they should to clopidogrel, there is still a substantial number of patients that have recurrent thrombotic events. And because the newer agents are more efficacious, they have an advantage in that regard as well, in that regardless of intrinsic platelet resistance to clopidogrel, the fact that these agents are more efficacious means that they will reduce the incidence of recurrent thrombotic events.
Thank you. And Peter, I think this takes us very, very smoothly into the question I wanted to ask you. You presented data from Triton and Plato, the big studies dealing with the new drugs. And what are the main findings in these studies that have actually, in a way, made the big societies go for these drugs or incorporate these drugs into the guidelines?
Well, that's quite a mouthful to do on camera, because these are big trials with almost 20,000 patients and almost 15,000 patients, and to summarize all the findings in a few seconds is tough. But I think if we look at ticagrelor, of course in the Plato trial, I think you did have a significant effect, so it did meet the primary endpoint. And in secondary analysis, we saw that there was an impressive decrease in cardiovascular mortality, but also in all-cause mortality, which was one of the first trials with new agent that have actually managed to show that. And then there are also, across a wide spectrum of patients, so this being an all-comers trial, and with subsequent sub-studies that have addressed issues in various subgroups, we find that there's good concordance whether it's patients undergoing bypass surgery have a very good effect. The patients that are ACS patients but medically managed have a very good outcome with ticagrelor compared to clopidogrel. So it's, I think the advantage of ticagrelor is it being a sort of all-comers drug in ACS with a moderate to high risk. Now with looking at the prasugrel data coming from the Triton trial, we've seen that also that was a positive trial in terms of the composite endpoint, although for mortality and cardiovascular mortality, that was only seen, in a secondary analysis in the STEMI subgroup, and also another high-risk patient population was the diabetics in Triton, had a very good outcome. And I think going back to what Albert just alluded to, sort of the entire burden of cardiovascular disease in these populations, we've seen studies now, both from Triton and recently published during the ACC Congress in Chicago, that if you look at all the events that you actually have in both trials, both Triton with prasugrel and Plato with ticagrelor, not just doing the analysis on the first event, but actually on subsequent events, you have a highly significant benefit of these drugs. Of course, this is playing a bit around with the statistic, but it's comforting to know. So the take-home message is that we've had prasugrel for 2 to 3 years in many countries. It has been established. There are some disadvantages with the drug, that you have to be cautious in the elderly and the lightweight patients, less than 60 kilograms. And also there's a contraindication in those with stroke and prior TIA. So I think to sum it up, I think prasugrel has been well established many places for patients with STEMI, and to some extent the diabetic high-risk population with ACS, whereas in countries or regions where they did not adopt prasugrel initially, I think I see a tendency towards using ticagrelor more broadly to this patient population.
There was a question as well in relation to clopidogrel and bleeding and preloading with clopidogrel, and the difficulty then of sending people for surgery if they need to. The question is probably for both. I mean, how serious that problem is?
I think that's a very important issue. I think it's important to realize that the label for both drugs, varies a little bit in different countries, but it is mandatory to be off the drug for 5 to 7 days with both prasugrel and ticagrelor. In terms of surgery, I'm not that worried. Just remembering one piece of data that I have in my head, when we did the second dynamic trial, which of course was a STEMI trial years back, almost 10 years since it was published, but in a consecutive series of STEMI patients, of almost 800 patients having primary PCI, only one patient went to surgery within 24 hours. And then there was a few that did the following 3 to 7 days. So it's a rare occurrence. And I think many surgeons in many of the large surgical centers now have experience with doing acute surgery with an ADP receptor antagonist on board. And admittedly, our own surgeons are always very frightened when we have once or twice a year when they have to do it. Not frightened, but they have respect. What I tell them is, just be very meticulous with your hemostasis and you'll be fine. It's important to realize if the patient has been loaded with one of these efficacious drugs, you can do surgery. Actually, there are centers that don't care about, the 5-day ban from these drugs and just operate. So what I tell the surgeons is, go ahead and do it, be meticulous about the hemostasis. Maybe don't close up the chest quite as fast as you would have. Have your assistant sit there for about an hour maybe. It might be necessary, but I think this is well invested in these acutely ill patients with left main disease or triple vessel disease, high-risk patients, if you can then wean them off.
Right. I mean, this also takes us back to what appeared to be a recurrent theme. I mean, Albert, you said, well, patient trials are slightly different perhaps from real-life patients, and we are basing our sort of practice on recommendations made by international societies who actually base their recommendation on very, very large trials, thousands of patients. So then the difficulty for the clinician is how do we extrapolate the findings in so many patients to our real life patient, the one we see on daily practice. And I think this is probably many countries and physicians are agonizing over what to do in real life with the guidelines, how to make sense of the controversy or the lack of consensus perhaps between American and European guidelines. So what would be your view on this?
I think the lack of consensus reflects the fact that there isn't a right and a wrong answer to this. I think we have the trial evidence. And remember, of course, that we have the Plato and Triton Timmy 38 trials with Skagel, Prascal, but they're really the only large trials that we have. We don't have any head-to-head trials between the two drugs, so we can't say that one is better than the other. We don't have any good cost-benefit analyses to really say that using these drugs is going to save lives, prevent hospitalizations, compared with using clopidogrel, say, in combination with platelet function testing. To come back to your question, I think there's no right and wrong answer, and that's very much reflected in the disparity in the guidelines between Europe and America.